broadcast, Heterogeneity and Resistance Mechanisms in Advanced Prostate Cancer by Dr. Raoul Concepcion. I'm Christina Jewell of LabRoots, and I'll be your moderator for today's event. LabRoots is the leading scientific social networking site, and we are proud to bring you this interactive web seminar. For more information, visit us at labroots.com. Here's how the presentation works. We want to hear from you. Questions, comments, and even answers can be submitted via the green Q&A button at the lower left of your screen. We'll try to get everyone, but if not, we will make sure to follow up with you by email. You can enlarge the slide window by clicking on the screen icon on the lower right hand of the corner of the slide window. If you can't see or hear this presentation properly, let us know by clicking on the support button at the top right of the Q&A button or in the lower left. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the CE button located at the bottom left-hand corner of your webpage and follow the process of obtaining your credits. I would now like to introduce today's speaker, Dr. Raoul S. Concepcion. Dr. Concepcion is the current director of the Comprehensive Prostate Center in Nashville. Dr. Concepcion was a general surgery and urology resident at Vanderbilt University of Medicine from 1984 to 1989. He served as chief urology resident from 1989 to 1990 and was also a research fellow in the Light Laboratories at Vanderbilt. He's been in practice since 1990, with his major clinical interests being urologic oncology, specializing in advanced prostate and bladder cancer and lower urinary tract reconstruction. He has an academic appointment at the Vanderbilt School of Medicine as Associate Clinical Professor, Department of Urology. He is board certified by the American Urological Association, the AUA, and is a member of that organization as well as the Southeastern section of the AUA, Society of Urologic Oncology, American College of Surgeons, and the Nashville Surgical Society. I would like to introduce Dr. Concepcion. Dr. Concepcion?
Great, Christy. Thank you so much, and welcome everyone this morning. Thanks for joining us. So for the next hour or so, we're going to talk about the heterogeneity and resistance mechanisms in patients with advanced prostate cancer. These are my current disclosures as of today. And this is a really germane topic. As you know, a number of advances have been made over the past 6 years relative to the therapeutics as well as the diagnosis and multiple modalities, imaging, etc., for advancing prostate cancer. So this is sort of your typical data. For 2016, we estimate that number of new cases will be down probably around 190,000. Much of that is related, as many of you may know, to the United States Preventive Services Task Force recommendation that has given PSA a D recommendation, which is a whole nother topic. But so prostate cancer, as we know, is the leading cause of solid tumor in men over the age of 50. And the number below, the 27,000 deaths directly attributable to prostate cancer, we know that prostate cancer is the second leading cause of cancer-specific death in men over the age of 50 behind lung cancer. So as we look at prostate cancer, it is really a spectrum of disease. And as urologists, we generally deal with localized disease because patients get referred to us for elevations of their PSA. We offer definitive therapy, historically speaking, radiation therapy, surgical therapy, we can do cryo. And now for many prostate cancer patients appropriately selected, active surveillance also is very appropriate. However, we know that a certain number of people, despite definitive therapy, will develop basically this biochemical recurrence. And what we mean by that is that their PSAs will start to rise. And once that happens, that generally portends to a worsening situation. And patients then usually get started on hormonal therapy. But at that point, they can actually migrate into two areas. One is where we know that patients actually become metastatic before they're even started on hormones. And the other one is when they develop this concept of castration-resistant prostate cancer, which by definition means prostate cancer on hormonal therapy, testosterone levels less than 50, and rising PSA. So this is sort of that hypothetical journey. Many of you have seen probably iterations of this slide, in that what generally happens is that once we start hormonal therapy, when the PSA starts to go up, whether this be castration, whether via surgically bilateral orchiectomy, or whether it be medical therapy, usually androgen deprivation therapy, what you see is a diminution in their PSA, but then historically what will happen in a percentage of patients is that you will start, the PSA again will start to rise. This is where urologists, we need to be more diligent in terms of trying to manage these patients, trying to identify metastatic disease, because right now the beauty about it is that we have multiple therapies that we can give first, second, and third line to, in these patients that develop metastatic disease. So what we're going to do is really talk about more the molecular mechanisms. And we talk about heterogeneity. This is not unique to prostate cancer, but probably most tumors exhibit some element of heterogeneity. And by heterogeneity, we can discuss between patient to patient, within the patient, him or herself, and obviously prostate is going to be himself, but even within the tumor itself. So let me give you examples of some heterogeneity. So this is from patient to patient, and what this slide depicts is that these are studies doing 30 rapid autopsies sampling of patients who basically passed from castration-resistant prostate cancer. And basically over here on the left-hand side of your screen, what you're seeing is that depending upon the patient, they can develop metastatic disease. Historically, we've always thought about prostate cancer. The majority of it does go to bone, which we know. Secondarily, we know it does go to lymph nodes. But you can see it can actually spread to a number of these different organs. And again, this is representative of 30 different patients, all dying of castration-resistant prostate cancer. On the right side of your screen, really within the same patient, within the same metastatic sites, you see different differentiation, different histopathology characteristics within the same patient based upon metastatic disease. And also, what you also see is that you get different expression of the androgen receptor, which we'll talk about more. So again, that is heterogeneity as we define between patient to patient. However, within the tumor itself, you can actually see heterogeneity. Again, you can get some areas here that have a lot of staining of the androgen receptor, and also have a differentiation of staining for temperance 2 ERG. And again, what you see here, again, within the same patient here, again, all with prostate cancer, within the tumor itself, you get high expression of androgen receptor, but in the lymph node, the metastatic site, you actually get low expression of the androgen receptor. And that's variable from patient to patient. Now, this is a very important slide, and I want you to recognize is that, as you know, when we do biopsies for patients with prostate cancer, we have historically woefully undersampled the prostate. And so what this slide depicts is that if you do your biopsy and you hit one of these green clones over here, you may mistakenly think, well, that's the primary clone, that's what's happening within the entire prostate. But lo and behold, what can actually happen is that there can be a small subclone, which you may not even recognize, that actually is going to be the site ultimately of metastatic disease. So again, this is heterogeneity within the primary tumor itself. And so again, this is not unique to prostate cancer. This is probably true for most tumors. This slide is also very interesting. Again, this was rapid autopsy, basically with patients who have passed from prostate cancer. And what we see here is we get polyclonal seeding. So in the left part of this screen, what you see here is that, and again, they did panomic sequencing on patients who had passed away from metastatic castration-resistant prostate cancer. And what you see here is that from particular clones, you get extension, you get seeding of one clone into the seminal vesicles and into the lymph nodes. And then from that seeding, you get branching into various areas outside the pelvis. But then from there, you can also get this very complex array of cross-seeding. And what was presented last year at Prostate Cancer Foundation is that some of this seeding can actually go back down and reseed the prostate, which makes us now really rethink about how aggressive we need to be with the primary tumor, even in the setting of metastatic disease. And so what we also know is that basically, depending upon the site of seeding, depending upon where basically metastatic disease is being detected, will actually have prognostic implications. And based upon this slide, we know that patients who have lymph node metastasis only generally enjoy a longer overall survival advantage versus patients who have bone, and certainly those who have a combination of bone and visceral disease. So there are two really models that are out there for the development of castration-resistant prostate cancer. One is what we call this adaptation model, which is what you have within the primary tumor is that you have clones that are sensitive to to hormonal therapy. And then once we start androgen deprivation therapy, again, whether that be by bilateral orchiectomy or medical therapy, you basically wipe out these hormonally sensitive clones. But then what is left are these other clones that are inherently resistant to androgen deprivation therapy, and then you get an expansion of those particular clones that result in advancement of the disease. So that's the adaptation model, or excuse me, that's the selection model. Then the adaptation model is really one where what you have, and probably this is a combination of the two, is that you have basically clones that are all sensitive to androgen deprivation therapy. And then once you institute androgen deprivation therapy, once you alter the microtumor environment, then what happens is that you get a development of cells that acquire additional features, whether it be mutations, epigenetic changes, that then render them resistant to traditional androgen deprivation therapy, resulting in a clonal expansion of resistant cells. And again, what this slide depicts is that for the most part, we know historically that the androgen receptor continues to play a major role in the development of metastatic castration-resistant prostate cancer. But we also know that there are AR-independent mechanisms, and we'll actually expand on those. So that's why, because of this continued dependence upon the androgen receptor, we have changed the nomenclature from what historically has been called androgen-insensitive, hormonally resistant, to this concept of castration-resistant prostate cancer. This is the Sentinel article that was published back in the 40s with Huggins and Hodges, who many of you know won the Nobel Prize. They were the only two urologists to win the Nobel Prize, and basically they found that prostate cancer was a hormonally driven disease. Now, what we know now, again, is this concept of the androgen receptor. And if you would have told me 7 or 8 years ago that as a urologist we would have to be fully cognizant, fully aware of the androgen receptor in order to treat advancing prostate cancer, I would have said, well, that's not going to be that relevant. But again, I am really pushing for those of you out there that want to manage advanced prostate cancer. It is incredibly important to understand the molecular components of the androgen receptor. So this is a schematic looking at the AR. So we know that the AR is coded for on chromosome 11 on the X chromosome. And really what it actually has 4 major functional domains. So again, so it starts out here as this is basic DNA, RNA transcription translation. So it starts out on a number of exons on the on chromosome 11, which results into basically transcription into messenger RNA. And so the protein itself, the actual androgen receptor, which is a function of translation, has 4 distinct regions. One is what we call the N-terminus, and basically this area is responsible for the majority of transcription activity. You also have this DNA binding domain, which is responsible also for transcription when you get nuclear translocation. In between the DNA binding domain and the ligand binding domain is actually this area called the hinge region, which is responsible for nuclear translocation of the androgen receptor. But the fourth area, which is really important to understand, is this ligand binding domain. And the ligand binding domain basically is coded for through exons 4 through 8. This is the area that actually will bind the androgen, will bind dihydrotestosterone, which is a much more powerful androgen, which starts the whole mechanism. So again, this is sort of the canonical pathway that we talk about. And many of you know this, but it's always good to rehash this. So what happens is that you get testosterone that's circulating either bound or free. When it's bound, it's usually bound to sex hormone binding globulin. You dissociate testosterone from sex hormone binding globulin. You then have diffusion of testosterone from the extracellular space into the intracellular space. Once inside the intracellular space, testosterone is converted to dihydrotestosterone, which again is a much, much more powerful androgen by an enzyme called 5-alpha reductase. Within the cytoplasm of the prostate cell, you have the androgen receptor. The androgen receptor usually has a chaperone molecule, usually heat shock protein. Once it sees free androgen, you get dissociation of heat shock protein, of the chaperone molecule, and you get binding of the androgen to that ligand binding domain. That results in dimerization of the receptor complex. You get then nuclear translocation into the nucleus. You then get binding of the receptor ligand complex via the DNA binding domain to DNA, which then starts the process of transcription to messenger RNA and then to translation. And because of that, because of this process, because of this androgen-driven event, what pops out are a series of proteins, PSA actually being one of them. And it's very important to understand that. But also that also results in prostatic cell growth and survival. So again, this is what we call the canonical pathway, and again, it is all driven by the androgen receptor. And so prostate cancer, again, what we recognize is that it continues to rely on androgen signaling, binding androgen signaling. So again, as we look down here, this is again the whole pathway again. But what we know is that there are numerous adaptive mechanisms that, despite manipulating the androgen axis, whether it be by lowering testosterone or binding up the androgen receptor with androgen receptor inhibitors, you have all these different pathways in which the cell, which is the prostate cancer cell, can continue to survive, continue to evade apoptosis, which results in progression of the disease. And so, again, this is sort of this slide that we showed earlier, is that they are androgen receptor, there are AR independent mechanisms, and then there are AR dependent mechanisms. And we'll go through these because this usually then is how we understand the various targets. So if you really want to start looking at this from a genomic standpoint, this was an article that was published in the Journal of Clinical Oncology, it's a great review article. It's from the folks up at the University of Michigan, Raoul, and many of you probably saw this that was published in Cell last year, and this was funded by Prostate Cancer Foundation and the Stand Up to Cancer. And again, these are very good review articles that talks about the molecular pathways and the importance of clinical genomics. What they found, and again, these were biopsies, and these were patients that passed away from castration-resistant prostate cancer, 150 patients. They did pan-omic sequencing, and what they find is that there is a number of driver aberrations that they identified through genomic sequencing. So on the left-hand side here, you see a number of what these aberrations are. You get somatic mutations, gene fusions, homozygous deletions, androgen receptor amplifications, and what's becoming more and more important now, and there was a recent article in the New England Journal of Medicine about the possibility of these germline mutations, especially as it relates to DNA repair mechanisms. So these are all the driver aberrations on the left, and then these are the potentially actionable mutations that we actually see. And much of them involve AR amplification or mutations, PI3K, but again, a lot of attention is going to be paid with these DNA repair mechanisms. So again, getting back to this concept of heterogeneity, we know that you can get genetic alterations to drug targets. And remember, a lot of the targets right now in terms of the newer medications are developing towards the androgen receptor. So when you look at trying to look at particular targets, you can kind of break them up to drugs that will actually decrease gonadal or circulating testosterone. And again, this is working off the definitive article by Huggins and Hodges. So we've known about LHRH analogs, whether they be agonists or antagonists, that will actually cut down the levels of circulating testosterone. We want patients to have testosterone levels less than 50. There are also ways to basically influence that relative to looking at increasing sex hormone binding globulin, and as well as trying to decrease free testosterone. Secondary targets could be specifically looking at the less than 5% of testosterone production that comes from the adrenal gland. And again, when you look at the various ways to do that, historically, in the past, we have used ketoconazole, which is an antifungal, but now you have a whole number of different agents. The one that obviously many people are using that's commercially approved is abiraterone acetate. Then there's these other, the other targets could be actually where we're actually trying to take out the androgen receptor itself. So we can go after trying to look at things that alter the chaperone molecules, as I talked about, this heat shock protein, as well as agents that will downregulate the androgen receptor itself. Then you can again, this is an area that a lot of attention has been paid to over the years. Is basically blocking the androgen receptor. So we know that historically the first generation anti-androgens were flutamide, bicalutamide, nilutamide. One that was approved in 2012 in both the pre-chemo and post-chemotherapy space is enzalutamide, but then you also have a number of others in development, specifically ARN 509, which is now known as apalutamide. You have agents that you can try to block the nuclear translocation. Again, we are fully aware that enzalutamide actually may do that, but what we are aware of is that your traditional cytotoxic chemotherapies, your microtubulin inhibitors, one of its mechanistic actions may actually be preventing of the nuclear translocation of the receptor ligand complex. Then you can interfere with androgen receptor enablers, you can block co-activators, and then you can also try to take out the downstream effects. Again, this is going to be a whole area of increased mechanistic actions in drug development, looking at PI3 kinase, mTOR inhibitors, etc. So these are all the potential ways to specifically look at targeting the androgen receptor. And again, this is a very complex slide, but here on the right, what you're seeing here, again, is sort of a summary of potentially everything that we talked about within the previous few slides. So, just some specifics of some certain mutations that have been identified recently. This was an article back in Cell in 2013, where they actually found that there was a gain of function in dihydrotestosterone synthesis. So remember, dihydrotestosterone is a byproduct of the conversion of testosterone to dihydrotestosterone by the enzyme 5-alpha reductase. So whenever we lower circulating testosterone, whether usually, again, that be castration, we are seeing a lowering of dihydrotestosterone. What this article, and this came out of the group at Southwestern, is that what they are able to find is that you can actually get dihydrotestosterone synthesis through another enzymatic reaction that's not using testosterone as the precursor. This is another study looking at epigenetic mechanisms in terms of its role in androgen receptor targeting. This is an article that was published again in Cell, where they found that you can get activation of the androgen receptor complex not by the testosterone mechanism, but actually through the glucocorticoid receptor. And what makes this important is that one of the agents, as you know, that we currently use to block androgen synthesis actually requires the co-administration of a glucocorticoid. And again, based upon this article, that actually may confer some element of resistance as well. Again, getting back to the heterogeneity-induced mechanisms of action, so we talked about genetic alterations to the androgen receptor. We also talk about the expression of multi-drug-resistant pumps and as well as areas to evade apoptosis. So in terms of multi-drug-resistant pumps, we know that there are efflux pumps, there are efflux protein pumps that actually can confer resistance to certain therapeutic agents, specifically chemotherapeutic agents. And so we know that looking at messenger RNA, that some of these proteins actually have overexpression, and those cells that have increased overexpression of that protein are going to be more highly chemoresistant to many of our cytotoxic agents. In terms of mechanisms to evade apoptosis, we know that you can have altered microRNA expression and altered chaperone expression. So microRNAs are small RNA molecules that target specific messenger RNAs and prevent expression of targeted genes. So again, if they're preventing expression of targeted genes in protein, then if you get dysregulation, or where you get an increased amount of this microRNA, that can actually lead to chemoresistant cells because you are preventing the translation of these targeted proteins. And again, this was an article came out of Dana-Farber that actually looked at that. You can have altered chaperone molecule expression. This is really a lot of work that was done in the Vancouver Prostate Institute, Prostate Center, looking at an agent called CLUSTErin. As we discussed, what happens is that the androgen receptor usually is bound in the cytoplasm by these chaperone molecules. So CLUSTErin is a molecule chaperone that has multiple roles, and overexpression of CLUSTErin is a potential mechanism for evasion of apoptosis. CLUSTErin activity has been implicated in chemoresistance, so what they're trying to do is target CLUSTErin to hopefully, again, reduce the amount of chemoresistance that can be required. So again, what this whole area of resistance is becoming more and more of interest. It's becoming an increasing problem. So when we talk about, again, this whole concept of castration-resistant prostate cancer, I want everybody to be very familiar with what this means. So again, for castration-resistant prostate cancer, it's a patient that has a diagnosis of prostate cancer, is on androgen deprivation therapy. Now, whether that be monotherapy using LHRH agonist or bilateral orchiectomy, or whether that be complete androgen blockade using ADT plus first-generation androgen receptor inhibitors, it doesn't really matter. But they have to be on androgen deprivation therapy. Testosterone level less than 50. We can have a whole nother discussion whether it should be less than 30, less than 20, less than 10. I think most of us believe the lower the better. However, despite having castration levels of testosterone, the PSA starts to go up. And again, these are the areas, these are the patients that are usually seen by the urologist. They're asymptomatic, but when the PSA starts to go up, I believe we as urologists, we need to be more diligent of looking for metastatic disease. So you will hear people talk about M0 and M1 disease. So the definition, when I talk about M0 castration-resistant prostate cancer, it's basically patients that meet the definition of CRPC. They are studied, and lo and behold, usually using traditional bone scan or CT, there's no evidence of radiographic metastatic disease. So that is M0 disease. Problem is that M0 disease, we all know where these patients are going, because usually within 2 years, they will actually progress to M1 disease. And again, M1 disease means that they meet the definition of castration-resistant prostate cancer, but lo and behold, when you image them using CT or bone scan, or if you're fortunate enough to be able to obtain sodium fluoride PET, choline, or possibly some of the newer agents, the newly approved amino acid scan, FACBC, or if you live in an area where you can get choline, you get identification of metastatic sites. And so again, this concept of M0 disease really is an unmet need in prostate cancer. And again, I believe that M0 disease, we will probably see less and less of this as we start to utilize, as more advanced imaging becomes available. So the problem with M0 disease currently is that none of the agents that are currently approved for M1 disease are actually approved in the M0 space. So when you look at AUA or NCCN guidelines, what is approved in the M0 space is clinical trial or observation. Now there are a number of sponsored trials that are currently underway that are looking at utilization of therapeutic agents, enzalutamide, apalutamide, and ODM-201 within this M0 space. So this is really an unmet need. And as many of you know, since 2010, what we've had is a slew of therapies that have been approved since the original approval of docetaxel in 2004. There have been a number of key clinical trials. Some of them have been positive, some have been negative. And again, this is a summary of all the drugs that have been approved since 2010. So docetaxel was the first agent that was approved in 2004, and with an increase in median survival of 2.6 to 2.9 months. Jevtana or cabazitaxel was approved in 2011 with a survival benefit of 2.4 months. Then you had abiraterone acetate or Zytiga that was approved in the post-chemotherapy and in the pre-chemotherapy space, followed by enzalutamide, again in the post-chemo and pre-chemotherapy space, followed by radium-223. So as many of you know, abiraterone acetate is an androgen synthesis inhibitor. Enzalutamide or Xtandi is an androgen receptor signaling inhibitor, and radium-223 is an alpha-emitting radiopharmaceutical. So since 2016, where we've been, again, this area is expanding. So where we've been prior to 2010 is that we've had one drug approved, which was docetaxel. But then since 2010, we've had 5 newly approved agents. The problem that we have is that all those trials that I had mentioned in the prior slide were all monotherapy trials. So we have a real knowledge gap, if you will, in terms of optimal timing and use of these agents in combination, in layering, or in sequencing. One of the things that we've talked about, and many of you have probably heard about this, are what we call these androgen receptor splice variants. And again, that's why I really stress the concept of the understanding of the androgen receptor. And so, in review, again, the androgen receptor has 4 distinct areas. it's got this N-terminal DNA, N-terminal domain, which results in transcription. You get this DNA binding domain that comes into play when you get nuclear translocation of the androgen receptor complex into the nucleus. You get this hinge region that helps with nuclear translocation. But again, in exons 4, that's coded for by exons 4 through 8, you get this ligand binding domain. But what a number of scientists and researchers have found is that you get these variations. Really, much of this is due to treatment pressure selection. So the one that's gotten a lot of attention recently is basically what we call the ARV7 splice variant. So the androgen receptor, the ARV7 splice variant, again, if this is the full-length AR, and again, what is important is this ligand binding domain. So in review, the ligand binding domain is what binds within the cytoplasm. That's where the dihydrotestosterone basically sits on the receptor. What we have found is that in this ARV7 splice variant is that the ligand binding domain drops out. So you would think, okay, that would be a good thing, because if it can't bind ligand, if it can't bind dihydrotestosterone or testosterone, then it should shut down the androgen receptor. And lo and behold, what they have found is that, unfortunately, you can actually get the receptor still stays active despite not binding ligand. And so we think this is an area that is really brought on by the use, this treatment pressure selection, utilizing a lot of the agents that we're talking about in terms of that manipulate the androgen axis. So many of you have seen this data. This came out of Johns Hopkins. This was Emmanuel Antonarakis' data that was presented a couple years ago at ASCO, as well as the AUA, and published in the New England Journal of Medicine. And what the group at Hopkins did is that they took patients who had been treated with abiraterone or enzalutamide or a naive, and they tested them using circulating tumor cells for the presence of the ARV7 splice variant. And lo and behold, what they found is that if you were ARV7 positive, here again, what happens is that these patients, it drops the ligand binding domain. But if you're ARV7 positive and then you get treated with a androgen axis manipulator, whether you're trying to use abiraterone acetate or enzalutamide, you basically have no PSA response. Which makes sense, because again, what abiraterone and enzalutamide, they are manipulating the androgen axis by either dropping out testosterone or binding up the androgen receptor. And enzalutamide, or even apalutamide, has to bind to that ligand binding domain. So if there's no binding domain for it to act on, then, or even if you have a decrease in circulating testosterone, the drugs aren't going to have an effect, and therefore that's why patients that are exhibiting that ARV7 mutation really won't respond. But then if you look at what happens if they ARV7 negative, where the ligand binding domain is intact, then you obviously see a very impressive result in PSA response. And then when you look at basically response in terms of radiographic progression-free survival, as you might expect, patients who are ARV7 positive really had a much more rapid progression. And again, this is basically whether you were treated with enzalutamide or abiraterone, you see basically the same pattern. So patients that exhibited who were ARV7 negative across the board, whether or not it was abiraterone or it was enzalutamide, basically had a better response to therapy. So we know that 2/3 of patients with metastatic castration-resistant prostate cancer have tumors with intermediate or full resistance to AR targeting agents. So again, you can actually follow this clinically, and this is sort of, again, how I think you should look at it. So you can have primary resistance, intermediate resistance, and AR sensitive. So what I look at when I clinically start patients on some of the androgen axis modulators, basically I try to check their PSAs quite regularly during the first 3 months. And so what happens is that you can predict that if they're AR sensitive, what you are going to see if you look at the y-axis, which is PSA decline, those that are AR sensitive generally will have a very rapid reduction in the androgen receptor. However, again, just as we have looked at from the anti-Neurocus data, what's going to happen is that these patients that are intermediately resistant, what you may see is a drop initially, but with time, with continued therapy, that you will then see a rise in the PSA. You are going to have some patients, however, that will see very limited changes in their PSA, and probably they already have a primary resistance mechanism to androgens or to androgen modulation. So again, this resistance to ADT, to anything that involves the androgen axis, can be related to androgen receptor mediated mechanisms, including mutations, amplifications, splice variants. You can get upregulation, again, to other factors that continue to drive the androgen receptor. And again, though, you can get due to treatment pressure selection, you can get these androgen receptor mediated mechanisms where you get activation in the AR with all these different types of mutations that we discussed prior. Again, this was that same paper that I was telling you about earlier, where you get glucocorticoid receptor activation, and this tends to happen after, again, certain treatment. So again, this is a very complex slide, and so in summary, what's happening is that what used to be all this, where all we really understood was the role and the continued requirement of the androgen receptor. What we're seeing now is all these potential mechanisms that are targets, and so this is where a lot of research is going. And again, in future, how we're going to treat advanced prostate cancer in the future is really probably going to be looking at novel mechanisms, and we're going to need to be targeting a lot of different areas. We know a lot of metastasis in prostate cancer is directed to with metastatic disease to the bone, so manipulating the bone microenvironment. As we know that one of the hot areas right now across all tumor types is looking at the immune system, looking at checkpoint inhibitors, PD-1 and PD-L1 inhibitors, as well as CTLA-4, but then again, all these different mutations that happen within the prostate itself, within the primary, that not only looking at the androgen receptor, but looking at all the other potential co-activators that can continue to stimulate the androgen receptor and have escape pathways. So that concludes my presentation. Be happy to entertain any questions that are out there, any comments.
Thank you, Dr. Concepcion, for that very informative presentation. Now, we want to get right to your questions and input, so here's a reminder of how to let us know what you have to say. Questions, etc., can be submitted via the Q&A button at the lower left. We will try to get to all of you, but if not, we will be sure to follow up after the broadcast. So let's get to our questions. Okay, Dr. Concepcion, question number 1. How many are actively treating mCRPC patients within their practice?
Well, and again, I think that in the New World Order, I think that historically speaking, prostate cancer has always been the domain of the urologist. As many of you know, we make the diagnosis of prostate cancer because of the fact that patients get referred to urologists by the primary care because of an elevation in their PSA. Now, I think we as urologists, we need to continue to refine PSA. We know PSA by itself is not a perfect test. We know that there are other adjuvant testing, both liquid, urine, and blood, potentially imaging that might help us. But I think with all these newer therapies, I think it's important, especially as we get into the changing environment and reimbursement, where urologists, I think, continue to need to be the lead, not only in diagnosing, managing localized prostate cancer, but at the same time, even as they advance, we need to be more diligent in defining patients who may be suffering or may have progressed to metastatic disease, because now we have all these new therapies. I think this needs to be a multidisciplinary approach. We need radiation oncologists involved. We need medical oncologists. But again, I really encourage the urology world to want to try to really get a better understanding of these mechanisms and how to best manage these patients.
Next question. Are there any current prostate cancer immune cells management to resolution or cure?
Yeah, that question really, would be interesting to hear from the participants viewing how many urologists are out there, and how many of them are actively trying to manage advanced prostate cancer.
Dr. Concepcion, how many urologists are on the line?
No, that's actually was one of the questions that I had posed. I don't know if any of the audience wants to sort of give themselves up, if you will, and how many urologists are out there, and if this, because again, as I just mentioned, I think that this is very important for the practicing urologists, and it's not just for people in the academic settings. I believe as we see more and more advanced prostate cancer, everything that we're talking about here, all the newer therapies, it's important to understand how they all work, and the molecular mechanisms.
Well, if there are no more questions, I would like to once again thank Dr. Raoul S. Concepcion for his presentation. Dr. Concepcion, Do you have any final comments for us?
Well, and again, I first of all, I want to thank everybody for jumping on this morning. This is a new area. I tried to make this somewhat simplified. I think, again, in summary, I think it's important that we understand that the androgen receptor still plays a role in the progression, but as we know, there are a number of mechanistic actions, both related to the androgen receptor as well as the as non-AR mechanisms that play a role. And I think to understand this disease state, you really have to understand all the molecular mechanisms. So it looks like there's a question from Michelle. Will immunotherapy address the polyclonal mechanisms of metastatic cancer? That's a great question. So the thing about immunotherapies, and so there is one immunotherapy that's currently approved for metastatic castration-resistant prostate cancer, which is Circulating T. So Circulating T is an autologous immunotherapy where we basically are stimulating the patient's own immune cells in order to actually treat the disease. That's been approved since April of 2010. So Circulating T has been around for a number of years, and it's active immunotherapy, but it really should be used very, very early on in the diagnosis and in the identification of metastatic castration-resistant prostate cancer. Now, I think with some of the newer immunotherapies, and again, much of this is being directed towards these, what we call checkpoint inhibitors, PD-1, PD-L1, CTLA-4. What those therapies are trying to do is to unlock the immune system. The checkpoint inhibitor proteins, or the checkpoint proteins, basically keep the immune system intact, and it also prevents basically the immune system from overreacting. So by blocking those checkpoint proteins, by using checkpoint inhibitors, then what you're doing is that you're unleashing the immune system. The problem is that not all prostate cells basically will express high amounts of PD-L1 or CTLA-4. So that's the problem, is that not all prostate cancer by itself, using immunotherapy by itself, it won't be the complete answer. I think, Michelle, to answer your question more appropriately, I think using immunotherapy in combination with other therapies actually has a more potential for essentially treating some of these advanced states. There's an entity out there called the abscopal effect, and the radiation therapists talk about this a lot. So the abscopal effect is the use of primary radiation, which results in cell kill and then antigen spread. So in theory, what you could potentially do is use systemic radiation, say maybe even radium-223, given in combination with some of these immune therapies. As we talked about earlier, and I'm going to go back to this slide, that one of the things that's becoming more germane is this concept of small clones within the prostate being the clone that actually results in metastatic disease. And again, when you look at this particular slide, when you look at this particular schematic, what we also know is that some of these metastatic sites can actually go back and reseed the primary tumor. So even in the setting, and there's been a lot of interest in this over the past couple of years, even in the setting of metastatic disease, clearly oligometastatic disease, low volume disease, there are some studies now, there are some theories, some thoughts about going ahead and aggressively treating the primary, whether that be removing that surgically or radiating it to prevent this reseeding. So again, I think immunotherapy, lots of interest, and again, a lot of this is going to play out as we do more studies looking at combinations, and as we get more aggressive in terms of doing genomic sequencing, not only of the primary, but as well as the metastatic sites.
Thank you again, Dr. Concepcion. Now, if we weren't able to speak directly with you today, we'll be sure to follow up with you. Thank you for participating. And we want to thank today's presenter as well as labroots.com, the leading scientific social networking site. For more information, visit us at www.labroots.com. Today's webcast will be available for on-demand viewing on our website through February 2017. We will let you know when it's been posted, and we hope you pass that information on to any colleagues who couldn't take part in today's broadcast. Thanks for joining us. We hope to see you next time. Goodbye.